before Ruth introduced the speaker, just for everybody to remember that these grand rounds, even though we have an agenda, we have open topics, and if anyone would like to submit a topic for us to discuss one of these Wednesdays at noon, the concept is to keep discussing topics related to healthcare epidemiology, infection control, antimicrobial stewardship, and then today we are going to, and everything that is relevant for us working in these areas in different healthcare settings. Ruth, you want to introduce Hudson?
I would be delighted. So Dr. Hudson Garrett, that is, I'm sure, well known to most everyone in the infection prevention and control world, either in the acute care setting, long-term care setting, industry. Hudson has had quite an impact and influence in his career as part of infectious diseases, infection prevention and control. I'm happy then to have the opportunity for him to bring in information that really is incredibly timely and is really you know, at the cutting edge of information as it comes out to us. Hudson has been part of the OSHA school, learning then all of the aspects regarding the regulation designed to protect healthcare personnel, protect workers in healthcare settings. And in doing that, he provided us an overview of the OSHA standard as it is right now related to COVID-19 and what we are doing in acute care settings. Today, he's going to focus on what is happening in skilled nursing facilities from the Centers for Medicare Medicaid Services. But this is important that I think we look at this, that this is not only focused on what is happening in one side of the healthcare industry. Instead, it's important that we know what is the focus of the federal government in looking at what is happening with respect to safety of patients and the safety of healthcare personnel. And as we have patients moving back and forth across settings and healthcare personnel moving back and forth across settings, this was very timely for us to be able to get Dr. Garrett to get his insight, what he is learning as part of his work with OSHA and across healthcare settings. So with that, Hudson, if I can turn this over to you to get us started today, and thank you very much for leading this part of the Grand Round series.
Thanks so much, Dr. Carrico, and we apologize for the ding-dongs. We will try to get that fixed on the back end. In addition, there will be an ebook that's available where I've taken the different tools and resources that I'll be mentioning to today's talk, and those will be available on the Institute website. So we'll make those available also on the YouTube. So you'll be able to download those following today's program. Before we get started, I understand that there may be a few folks that are a little bit newer to healthcare. And so Dr. Ramirez asked me to just very quickly sort of highlight the role of CMS, which I thought was a very good ad. So if you're not familiar, which I think most of us are, but just in case you're not, CMS is the Center for Medicare and Medicaid Services. It is part of the federal government. It's really the largest payer that we have in the United States. And specifically, they sort of have two different roles. One is obviously as a payer, the other is as a regulator. And so CMS specifically looks at regulation of skilled nursing facilities, dialysis, acute care facilities, and a couple other places. And they also issue deemed authority to certain accreditation bodies like the Joint Commission, DNV, HHHC, to go out and inspect healthcare facilities. In skilled nursing, of course, they have a little bit more of a direct role in that inspection process. And so not only are they again paying us from the Medicaid and Medicare standpoint, but they're also directly regulating skilled nursing facilities. And so that's what we're going to be spending our time talking about today. And that's really our first objective, is to look at some of the things that CMS is going to be rolling out federally and sort of the timelines associated with that, as well as the executive branch infection control initiatives that are going to be rolled out for long-term care facilities. We'll talk a little bit about the revised visitation guidance, which I was glad to see come out so that we can fully make sure that family members can see their loved ones. I think that was a huge miss that we can all appreciate. And then also we'll spend a little bit of time talking about current and future challenges. Just to give you some idea of the scope, because I know not everybody on the call comes from that long-term care background, and I see a lot of our regional infection preventionists from the Department of Public Health, so glad to see many of those names there. But we've got a lot of folks that live in skilled nursing, well over 1 million individuals, and we certainly have a large number of licensed facilities, right? And so this is pretty wide and broad across the United States. And if you look at the overall, data, we're approaching almost 200,000 deaths in COVID-19, specifically in the resident population. We'll sort of talk about that in the context of staff members in long-term care, as well as residents here in just a minute. But overall, that represents about 25% of the overall folks that have not survived COVID-19 infection. Now, what I thought was interesting in
3 months.
Yeah.
and if you could just make sure you mute your phone lines, we'd appreciate it. What I thought was interesting in this recent document from the White House was when they looked at sort of the CMS surveys, and particularly looked at the infection control perspective, right? From 2013 to 2017, we're talking about almost 90% of all facilities that were inspected had some type of deficiency in the infection control space, right? That can be something as basic as hand hygiene or disinfection or appropriate use of PPE, or even something more egregious, right? This tells us that the scope and magnitude of the issue with these deficiencies is pretty widespread. And it also tells us that we've got a lot of room to grow in some of the specialization needs that might need to be present in skilled nursing facilities. Now, if we look at the sort of data that specifically comes from CMS, right? And we look at the total number of cases in long-term care that have had COVID-19. You can see that there on the left. You can also see the number of deaths. You can also, on the right side, see the vaccination population, right? And so this is going to be an important element as we look at boosters, sort of this new term of up to date, how that's going to translate, especially for staff members that were not vaccinated. We've seen some spikes where you'll see that the resident infection goes up as well as the staff infections. And we know that especially during the sort of height of the pandemic, we weren't letting people into skilled nursing facilities. And so the infections were coming in primarily through the staff members. And so there's something to be learned from that. And I think one of the most tragic things that we can all agree to is when we keep families out, we know that the healing can't take place. And certainly that is an important element, not only true for skilled nursing facilities, but also for any healthcare facility. I know when my own brother was hospitalized during the pandemic, it was extremely stressful for my parents because they couldn't go see him. And it definitely, took its toll on that. So I thought it would make sense to quickly look at some data. This is specifically pulled from NHSN, which is the National Healthcare Safety Network from CDC. This is going to be data through, you can see the data is published as of March 29th, but you'll notice that it is not through March 29th here. Overall, though, you can see the blips are very interesting. If you look on the left side, that's going to give you your total number of deaths. On the right side is the total number of cases. You can directly see the correlation with a few exceptions. On the right side, you'll see that especially in the January 2022 timeframe, we saw a pretty big increase in total number of cases. Luckily, the mortality was not there. And so that was a positive thing. It'd be interesting to sort of overlay that with the last 2 years, and you would see that there would not be that same statistic there. Well, let's look at staff members, right? This is another important element. Again, on the left is going to be cases, and then on the right, you're going to see actual deaths. So you see a very similar curve here in January of 2022, specifically after that holiday time period, going back sort of, leveling out a little bit there. And then you'll see on the right side that the death rate did actually spike a little bit. And so when we think about overall risk, right? And if you joined us for our OSHA Grand Rounds, I think I did 2 weeks ago, this is one of the core topics, right? We can't just protect the resident. We can't just protect the patient. We've also got to protect the healthcare staff. And skilled nursing is such a specialized area where that very particular care is provided. They have those really long relationships with those residents. It is tragic to lose those caregivers that are so good at what they do. And so we want to do everything in our power to keep them as safe as possible. Now, there's a couple of things that are big buckets that we can look at for opportunities for improvement, right? One is to look at sort of who is running these facilities. And this is where I think it gets quite interesting, right? There was a lot of data that was mentioned in this recent publication looking at sort of who owns the facility. Is it someone with a good track record of running skilled nursing facilities? Is it a private equity firm, as an example? And one of the first studies that I've highlighted here, and these are live hyperlinks, so you can actually go read the study, they found that if the facility was acquired by private equity, that there was almost a 12% increase in preventable emergency department visits. That's pretty telling, right? And so it goes back to leadership and management as the sort of fundamental element of a good infection control department, and really the program itself. If we look at that a little bit more detailed, you can find that they also have things with like antipsychotics. And we know that this is a huge area of focus. And again, this is tied back to private equity. Now, I want to be careful in saying that this is not to say that all private equity is bad, right? It just says that this is the data that was pulled, and it does tell a story that we need to look specifically at who is really qualified to own these facilities, who needs to run them, right? Are they properly resourced? From that perspective. And the last study I thought was particularly troublesome, and it really looked at private equity-backed nursing facilities, and their overall infection rate and death rate were 30 and 40% above statewide averages, right? So again, this is a very big red flag that I think we definitely need to take a further look at. So in this executive target list, if you will, they're really looking at three big buckets, right? They want to look at adequate staffing in long-term care, which we know is a challenge for all of us across all healthcare settings, not just skilled nursing. Number two, I think, is so important, which is the dignity for the residents, right? And the safety in their accommodations. What's so different about skilled nursing is that this is not a hospital room. This is their home, right? This is their communal living environment. It's not just their dining room. This is their personal dining room. When they go to the gym, that is their gym. It is, you have to treat it so differently, right? And that's why skilled nursing is really a double-edged sword. It provides a lot of benefits to those residents, but it also creates some very unique perspectives from an infection control standpoint. We can't just move everything out of their room and clean it as easily as we could in an acute care environment. And last, but certainly not least, is the overall quality of care. What can we do to improve the quality of care that we're providing and make it more reliable and consistent for all involved? Well, they broke this down into a couple large buckets. The first was really looking at, are we spending money in the right areas, and are we frankly getting a return on our investment? And there's some very interesting and telltale signs here. The first, which we've heard many times before, is sort of creating a staffing ratio, right? They didn't define what that was, but essentially said they would commission a study. And I think we've heard these words before, right? But do we know, for example, what the right staffing ratio is? I would say we don't. We've seen this done in states like California, where there are sort of inpatient environments where there are ratios. We've not necessarily seen a change in the patient outcomes. And so I think in skilled nursing, even being more specialized, we've got to do this very carefully so that we do define with good, reliable, and reproducible data what that staffing ratio should be. Right? Is it based on RNs? Is it based on LPNs, technicians? Certainly we want to look at our therapists. So it really needs to be an interprofessional approach to properly delivering care for those residents' needs. We also know that the residents' needs change. And so as their acuity changes, we may need to change our staffing model. The sort of second area, which I think we can all appreciate, is we want to reduce crowding. We know that not only is crowding not comfortable for these individuals, but it's also a huge infection risk, especially during a pandemic. If you've got a sort of a quad occupied room and you've got 4 people in there, that's a recipe for disaster, especially when one person has COVID or another transmissible disease, and we don't have somewhere to move the other 3 people. And so this can be problematic, especially for transmissible respiratory diseases, either through the droplet or airborne routes. The sort of third area is one that I'm pretty passionate about in general in healthcare, which is value-based purchasing, right? And this doesn't just mean products. This really means, are we doing the right things with the dollars that we have in order to drive the biggest quality outcomes and the best quality improvement for our patients and residents that we serve, right? We've seen this work effectively in acute care. It can certainly work when it is incentivized the right way. If we pay people to deliver quality, we know through experience that they will deliver better quality. But we can't deliver quality without good quality staff. And I think that, for those of us that have worked in long-term care, and I see several people dialing in from long-term care, that I recognize your biggest challenge, right, is to even get people to show up to work. And the last area here is sort of looking at safeguards around unnecessary medications and treatments. Antibiotics are a huge issue here, right? Do we sort of need to prophylactically give antibiotics if we've got an asymptomatic bacteriuria, right? These are things that we have to talk through so that we don't unnecessarily expose the patient to, things like antibiotics or even antipsychotics. It's not something where it's just easier to medicate the patient or the resident. It really needs to be what's right medically in order to treat them effectively. Now, we all know the old adage, accountability breeds responsibility, right? This is a great quote back from Stephen Covey years ago. But part of this is that we have to inspect what we expect. And that is a challenge, right? We have limited resources with CMS surveyors. We know that in addition, a lot of the CMS surveyors are not up to speed on some of these infection control topics. And so if I could leave you with one parting word, if you leave in work in long-term care, and you feel very confident that what you are doing is evidence-based and a surveyor says it's not, challenge it. Right? Pull out the CDC guidance, pull out the guidance from AMDA and other places and use it to your advantage. Never be afraid to stand up to a surveyor if you think that you're in the right? And especially if you're advocating for the safety of your team and your residents, be proud of that, right? Some of the best work in healthcare is done in long-term care, but we need to make sure that we can fund those inspection activities. These virtual visits that were done during COVID, they're just not the same, right? It just is not the same experience and it does not bring the same level of accountability, right? And we certainly want to highlight folks that do things really well and reward them financially and recognize them for that high performance. And we should equally highlight folks that are not performing well. Unfortunately, peer pressure works. And so we want to do that not only financially, but also reputationally and look at other enforcement sanctions that might be available to us. Part of this, right, is all about accountability of the leadership. And so as we look at the majority of long-term care, especially across the United States, is somehow affiliated with a chain or some other type of private equity group, we've got to look at standardization for ownership. Are these qualified individuals? Do they have the right skill set? Are they even legally entitled to own long-term care? All these are the sort of obligations that are done from a regulatory and licensing standpoint. And one of the big areas is public health, especially at the federal level, providing technical support. And we see that we've got several of our regional infection preventionists from the state on with us, which is great. And I'll tell you, if you've not reached out to them, please do so. Excellent people, great resources. We have Dr. Spicer on the line, I see as well. These are colleagues that are there to help, right? I think people are hesitant sometimes to call public health. Public health is our friend, right? These are immensely talented professionals that bring great value to the overall care that we're trying to deliver. One of the other areas that I think we can certainly appreciate as a consumer of healthcare ourselves is transparency. Right. This goes back to the pandemic. I want to know how many people in that facility are getting COVID. Where are they getting it from? What's the mortality and morbidity associated with that? What's being done? Are they able to isolate those individuals and quarantine them effectively? Right. But that again goes back to who runs the facilities. And so just like we have licensing databases and registry databases, we need something similar to that at the federal level to look at who is owning nursing homes and operating them. Are they qualified? Do they have a history of complaints in Nevada, for example, and now they want to move to Kentucky and open up a nursing home? How can we prevent that from happening, right? This is, again, trying to build that national database capability. And that's going to help us look at the financial practices, the operational, and certainly, and probably most importantly, the clinical care delivery that we're providing. Now, some of this can be reflected in the Nursing Home Compare website, but as we certainly all know, that can be a little bit difficult to interpret if you're not a trained person. And so I always have a little bit of trepidation when the public is looking at that, trying to interpret that data, because sometimes it's not always the easiest thing to do. So one of our big challenges that we face, and as again mentioned in this document, is how do we get the right people to work? Right? How do we make sure that we have people going into the field of skilled nursing? And the same is true in hospitals and ambulatory surgery and everywhere else. We know that we're sort of facing a second pandemic, which is healthcare staffing. And so we've got to create incentives and pathways to get folks to go into these fields. Going into long-term care is not for everybody. right? It is not for the faint of heart. It is a tough job. It requires a special level of compassion and dedication and, quite frankly, patience. And so it is not for somebody with a short fuse. And especially getting some of those more primary caregivers like our nurse aide colleagues and nurse technicians, the folks that are delivering some of that basic bedside care, can be very difficult. Getting them trained can also be expensive. And so there are many programs that are now becoming available that are being subsidized, and hopefully that will continue to change. The same is going to be true for our nurses, right? We know that we need more nurses in long-term care, and we can't just take someone from acute care and throw them into long-term care and think that they're going to be successful. And the same is true taking somebody from long-term care and putting them in the hospital, right? It's just not the same world. And it's not the same patient need. These are folks that you're going to be with for many, many, years, hopefully, in that setting. And so creating pathways to get qualified, highly educated nurses with good clinical assessment skill sets that can work collaboratively with providers is really going to be an important element of this. And certainly we've learned a lot of lessons over the last 2 years, I hope. And part of this is pandemic preparedness and looking at emergency response. What is the right amount of PPE that we need to have? When do we need to test? When do we not need to test? I know that, we think about RSV as an example. We saw tons of RSV over the last 2 years, which was just fascinating in the adult population. I know here in Atlanta where I live, we saw a ton of it. And so looking at sort of laboratory testing, what is ideal, what is not, what's overkill, what is acceptable, and then tying that back to vaccination status, right? And sort of the visitation piece is going to be an important perspective. One of the other elements that I was glad to see again mentioned, but it needs to become really mandatory, is the on-site requirement for infection preventionists. We know that good support from public health, good leadership support from the administrator, good medical director support, but also a good infection preventionist is a recipe for success, right? It will not only yield huge successful results for the resident population, but will also bring up sort of the overall delivery of care in that facility. It will make things more reliable, to make things more cohesive. And if there is, unfortunately, an outbreak or some type of infectious disease threat, you're able to respond to it a little bit more agilely. And that's an important element, right? We never want to get to know public health during an outbreak. We want to know them before, right? Make them your friends up front, make them your colleagues, and invite them in and make them a part of your extended team. We certainly want to also look at the lessons learned. This is an area that federally, I hope, CDC really starts to address very transparently and openly, where we look at sort of a postmortem. What worked? What didn't work? What are the things that we need to improve? How can we improve communication? How can we improve, distribution of supplies? What worked with vaccines? What didn't work, right? There were some amazing things that took place. I think we can all, create a whole list of things. And there were also some things that we could do more effectively. And that's what learning is all about. Right? When we don't learn from these opportunities is when we have failures, and we don't want to repeat the failures. We want to learn from those and move that needle forward. Probably the most exciting piece that I continue to harp on, this is my personal soapbox, is, I remember driving past a local nursing home almost every day on the way to the hospital. And there would be somebody standing outside, and it was this elderly gentleman, and he was out there every day of the week. Didn't matter if it was raining, shining, snowing, it did not matter. He was there, he was looking and trying to take care of his wife through the window. And I'll tell you, I wasn't even involved, and it broke my heart. And I can only imagine how he felt as a husband who couldn't see his wife. And it is something that, did it make sense maybe initially? Maybe so. Did it make sense to keep those restrictions? I just can't justify that in my head, right? We can certainly figure out ways to safely and reliably do this, like requiring that visitor to wear a good mask, making sure they do good basic hand hygiene, that we, encourage them to sort of stay separate from other people so that they don't have that issue. Certainly we can do this where there's not a big congregate setting, as an example. And again, working collaboratively with our local health departments that know that geography and know what sort of that community transmission rate is doing. So there are some things that we can do all the time, right? And those are those CDC core practices: wash our hands, use PPE appropriately, take catheters out when we don't medically need them. There's a whole list of things, right? But during a pandemic, we know that we sometimes shift into either contingency or crisis modes of care. And our goal is to get out of those as quickly as possible, because we know when we operate in sort of that no man's land, we have mistakes, we have errors, we have, sort of degradation of our clinical care that we're providing, and that is certainly not intentional. But we want to sort of learn and move past that as quickly as possible. We've got to do everything in our power to retain the staff that are well qualified and are serving our long-term care residents well. Staffing is probably the scariest thing I think in healthcare right now. It actually scares me more than COVID to think that we have facilities that can't even open beds because they don't have staff, whether that's nurses or physicians or techs or CNAs. It doesn't matter. We're all facing the same staffing challenges. We certainly recognize, and it's pretty clear from the memo from CMS and the White House, is that there will be increased scrutiny, right? And sometimes with increased scrutiny, there's pain, certainly, but there's also gain. And we want to make sure that hopefully we're going to be measuring the things that bring good impacts, that improve the quality of life for that resident, that make all of us safe, right? I think we have to talk about that openly, that it is not just about the resident safety, but also about keeping ourselves safe. If you look at the deaths of healthcare providers during COVID, that tells a story, right? And we need to learn from that. And lastly, the expertise that's going to be needed from a public health, infection control, and infectious disease standpoint, right, is enormous. We don't have enough infectious disease physicians across the United States. Facilities that do have an ID doc on staff are very fortunate. Having a good infection preventionist, very fortunate, right? So reach out, build those relationships, and also build those relationships with your external public health partners. They can be invaluable resources, both during an outbreak, but frankly, just on a good day. Because there's so many tools and sort of resources that they bring to the table in their armamentarium that we may not otherwise have access to. I've included a few tools and resources, and I mentioned I put together an ebook that we'll make available on the YouTube site as well as the Institute website. The first one is the White House briefing, so you've got access to that. I would strongly encourage you to check out the nursinghometrainings.org. This has got some free CE accredited programs that will help bring sort of everybody up to speed on infection prevention. You may be the infection preventionist, but make other people infection control advocates, right? Make sort of this training accessible to them. There's some great resources through AMDA as well. And then the last two are through the team at the Division of Healthcare Quality Promotion at CDC. And if you're not familiar with Project First Line, I would encourage you to familiarize yourself with that. You can also find information on that on the Institute website as well. And that's going to be a big focus for us moving forward, is bringing those frontline infection prevention practices directly into the hands of those that are providing care. So with that, I'll stop and see if there's any questions. And Dr. Carrico, I'll turn it back over to you to see if there's any questions or comments that you or Dr. Ramirez want to make.
Hudson, thank you very much. And I especially appreciate at the very end that you took the moment to highlight Project First Line. And if you look at the slide that you currently have up, you also have the Kentucky Infection Prevention Training Center website, the link. If you click on that link, and hopefully those of you that are on the call will write that down so you have time later on today or sometime to go to the website, begin to take a look at the information that is provided there. There's a complete page for Project First Line that has information that goes through the elements of that program. Now, it's basically an ad you've been intimately involved in, have done a lot of preparation for that material. These are the programs that have been developed by CDC that are designed to be basic for infection prevention and control. So in doing exactly what you mentioned, building the team at your healthcare facility, look at those Project First Line resources and begin to think about how you might be able to use those as you provide training within your organization, and take a look at how that can be of help to you really across your organization, not only the caregivers that are nursing, but also think about those caregivers that take care of the environment, the environmental caregivers. So everybody in the organization can have a role in that training. So I saw that we had already started with some amens as far as I think Lana uses that in her facility. So that would be great. And if you have comments, Lana, about how you've used that might be helpful to others as well.
Yeah, and keep in mind too that to Ruth's point, that the Project First Line is customizable. So for example, if you only have 10 minutes with folks in a nursing station, there's a 10-minute module. If you've got a little bit more extensive time, there's sort of a 20 to 30-minute module. And if you are really trying to do maybe new hire orientation, right? I'm a big fan of don't reinvent the wheel. There are great tools, and there's a 60-minute version. We've also uploaded different videos. And if there's something in particular that you need help with, feel free to let us know, and we can certainly create that. There's a lot of ability to sort of bring it down to the level of the audience. And so if we're looking at a CNA group, we can make that happen if it is something for nurses or administrators. But I think the most important thing about Project First Line is it needs to be interprofessional, right? It needs to be, the medical director, the nursing staff, our quality professionals, certainly our frontline clinicians, everybody together can bring that. And we see this with other things like antibiotic stewardship, where we've got to have our PharmDs and our other colleagues, and we can't do this in silos. That's the beauty of this project, is it really breaks down those barriers that have historically kept us in different boxes.
Great. Any questions about CMS and what kind of from the federal regulatory side, what this information is going to mean to us as we're caring for patients?
Hudson, since part of the problem, part of the regulation is going to be, okay, let's have a more infection prevention is in the area where the action happened, and I'm sure you've been thinking about it. How do you bring more people into infection prevention, and do you see an infection prevention is being in a particular long-term care facility, or you see an infection prevention is being a consultant that moves around? How do you see the person there helping?
I think that's a really good question, Dr. Ramirez. I think right now we see a lot of consultants that are roamers, right? They're moving around from facility to facility, which there can be a role for that. And I think that's more of that regional infection preventionist. And a lot of the chains have that. And I think that's perfectly appropriate, but you still need somebody in the facility, to your point, that's driving that true institutional change. That is really the boots on the ground, if you will, that can do that. And unfortunately, most people don't come out of professional school and say, I'd like to be an infection preventionist. They just don't have that sort of mentality. We are seeing a lot also of masters in public health students that are coming out that are entering infection control, and they bring a great skill set. They don't have the clinical background. And so we have to then have sort of programs, maybe like a fellowship or a practicum, where if you come from an MPH background, we give you that clinical skill set. We help you understand that. And if you come from a clinical background, we help you understand epidemiology. And so I think that the best teams in the world are those that are mixed up, right? MPHs, laboratorians, great PharmDs, nurses, all of those, combined with the ID expertise. But until we incentivize those people to enter the field, I think we're never going to move ahead. And so part of that is financial, part of that is sort of reputational and recognition, but we also need a standard that says you must, because we know that in healthcare, until we have a standard that says you must do this, it's not necessarily going to be, sort of taken, the baton's not going to be picked up.
At this moment, CMS doesn't say you have to, it's a suggestion that you
Correct.
You need to have infection preventionists in your facility. Correct.
And we've seen this also in ambulatory surgery. And I think that's been okay because of the nature of the beast there. It's a little bit more controlled, but in long-term care, we're dealing with very specific issues. We're dealing with a high potential for outbreaks, communal living environments, not ideal ventilation, right? So lessons learned from COVID-19, we know that all of those things could collaborate towards a bad recipe for disaster. And an on-site infection preventionist certainly makes a lot of difference. And I think if I was a large chain, I would also look at hiring an industrial hygienist that was really clinically skilled in working with infection prevention to optimize the environment. That is something that we know we can't tear down the buildings and rebuild them. We don't have money to do that all the time, but we can certainly optimize what we have and try to make it as safe as possible from an infection prevention standpoint.
I think your comment is great. That shows that we're going to have to bring a different type of depth to this. And I think COVID has shown us not only where we have a number of gaps, but a number of opportunities where we have, virtual connections, where we can bring some of these areas of expertise that may be really difficult to have in every setting, but connecting with whatever individual is responsible for the program in that organization, and then surround them with individuals that they can contact or that check in with them, maybe more of a proactive approach, so that we're bringing in that area that may be uncommon. Healthcare epidemiology, as you mentioned, the ID pharmacist that may not be present in every facility, industrial hygienist that may not be present, but bringing that, combining with the infectious diseases practice, that really demonstrates that it's not only acute care that needs this depth of skill set, but it is certainly long-term care as well. And so the faster we figure this out and figure out ways then to implement these programs broadly, then the better off our patients and residents will be with outcomes.
Well, and I think you brought up a great point that, was not mentioned in the CMS documentation, which was our feeder sources, right? So if we're receiving a ton of residents as new admissions from a particular acute care hospital, it only makes sense for us to have a great relationship with the IP over at that hospital, so that we understand what's coming to us, that we have good transition plans, so that we're not surprised by organisms that we didn't expect. Or, I've heard of, for example, somebody got transported with tuberculosis. Well, tuberculosis is not a reasonable organism to take care of in skilled nursing facilities. And so that was all preventable had there been a handoff between the infection preventionist. And so I can't stress the value of that enough, and also the role of public health, right? That is just such a huge thing. And if we've learned one thing through the pandemic, we absolutely need to resource public health. These are really talented folks that we need to do a better job of supporting. That's my crusade for the rest of my career, I think, for sure.
Well, I think you highlighted something that I know is particularly important to our Kentucky Department for Public Health. I know Dr. Kevin Spicer, Andrea Flincham have really been pushing that interfacility transfer, that exchange of information, so that whoever is the receiving facility has a better way of gathering the important information from the facility that is doing the movement, to do just those sort of things. How do we enable people to practice at that appropriate level and provide that level of safety and care for not only the residents, but those that are providing care in the facility? And communication is something we talk about a lot, but where we continuously find opportunities for improvement.
Well, and if you can fix two things, right, in life, it's communication and leadership. And that holds true in infection control. If you have a great, engaged administrator in skilled nursing, not only will you have better staffing outcomes because people want to work for that individual, but you'll have safer outcomes, right? But we've got to make sure that those are there, and we have to communicate vertically and horizontally through our organizations. So, there's great programs out there like Team Steps that are available through the Agency for Healthcare Research and Quality that really help break down those communication barriers. And Joint Commission has proven this over and over again with Sentinel events, that almost all of them have some route back to communication. And that's true with infections as well.
Well, thank you so much. And Dr. Ramirez, do you want to close us out for today?
Well, yes. Again, I thank all the participants. Thanks, Hudson, for bringing this topic. I think that this interaction that we're having is going to make us all know. First, we need to recognize the problem, then we need to act. We are going to continue going with these ground rounds. Please send us topics that you want for us to have in the ground rounds, and we keep sending you the different topics that are going to be coming. And as Hudson already mentioned, all these ground rounds are available, and we hope that you take the time to. I mean, he always gives us a lot of areas for us to go and click and keep learning. And Hudson, thank you for this excellent presentation. Thank you for your attendance. I will see you this coming Wednesday.
Very good. Next Wednesday, we'll be focusing on one of our PharmDs. Will be providing us some information on asymptomatic bacteriuria. And we look forward to Elena Swingler and her presentation then. So we'll see you back next Wednesday, our first Wednesday in April.